we are going to discuss on that regarding the atrial fibrillation. As we know, sir, the atrial fibrillation is one of the commonest arrhythmic disorder, even globally as well as in India. But if we find about the incidence rate of atrial fibrillation, it seems little bit to be unmatched as compared to the currently what the patients are coming in OPD and in your practice as well. So, sir, what is your take on this particular concern regarding the incidence of atrial fibrillation? That whether the whatever the currently reported globally, it's approximately 2%, whether it's actual or it may be under detected, and what is the status in India as well, sir?
Well, this is a disease mostly of the aging population. So, though you have statistics from the western part of the world where it's close to about 1 to 2%, India we really do not have a documented data about the incidence of atrial fibrillation. In fact, we are actually looking into a study from the Cardiology Society of India Kerala chapter. We are actually trying to start a registry also, but then the main problem is underdiagnosis. I think it's underestimated. No doubt, I think particularly in Kerala, the health measures, the quality of life, everything is better, and so we have an aging population, and I mean definitely the incidence of atrial fibrillation will be on the rise. So therefore, I think we need some real registry data to back up on this, and then I am sure it's indeed a very huge population at risk.
So definitely, sir, you have raised a point regarding the aging population. So as per one of the WHO survey, by the 2040, the Indian population must be crossing almost around more than 35% when the age will be more than 65 years of age. So definitely this kind of the disease where there is a age is one of the important factors. So we should have a earlier and on-time diagnosis before it's happening.
Absolutely right.
So regarding a screening part, what we are talking about screening part of atrial fibrillation, which is now getting very famous in a western part of the world. So what is the current status in India and how we can improve in India as well?
Well, if you look into the affluent population, no doubt I think most of the people would have a master checkup or let's say at least an EKG done. So that scenario, I think that's a subset of the population definitely would be diagnosed. But then the population at large, when you talk about a country like India, where the vast majority do not even have an access to primary health care, it's indeed difficult to screen them. But then I think over a period of time, for example, at least we have made tremendous progress in Kerala. I'm certain that most of the people, whether they're rich or poor, they at least from the cardiac perspective, they get ample opportunities for detection and treatment. So I think in the overall context, I think over a period of time there has to be better screening methods. At least an EKG for someone above the age of, let's say, arbitrarily you keep a particular age, because we know for certain that above the age of 65 years this is indeed a major problem. So I think that some screening methods and will have to be adopted to for a better diagnosis of atrial fibrillation. And one is this routine EKG can really pick it up. But then other thing is that I think tomorrow's world, I am sure with the technology just creeping in, the smartphones have become the fashion of the day. So today it's not difficult at all for someone's, let's say his oximetry or the oxygen levels, or let's say even his heart rhythm could be monitored. And then if everyone has a rich or poor has a mobile number, at least in Kerala I can tell you for certain, we probably have the maximum number of, I think the more than 120 billion users will be the projected figure. So if you have some access, some application where you can link it onto your mobile phone, so an EKG could be a rhythm strip could be done. So atrial fibrillation could be easy to diagnose. I think there's a bright future from that front.
Yeah, definitely. It's a very nice thought from your side that regarding we can have one center of the ECG database that from yes. Physicians you can collect ECG and they can send you the now WhatsApp is one of the best technologies also as well.
Not even WhatsApp. I think from the patient perspective, so if they can have an app which is downloaded. See, no one ever felt that WhatsApp could be so popular. Today, I see even the least educated person gets used to using a WhatsApp. So I'm sure this could be used for the help of the for medical community at large.
Definitely. So, sir, regarding a management part, if we talk about the atrial fibrillation, definitely rate and rhythm control remains the first priority to treat the atrial fibrillation. But if we talk about the complication of atrial fibrillation, so as we know that when the patient have the AF confirmed atrial fibrillation diagnosis, then there is a 5 times higher chance of risk of development of stroke. So regarding this particular stroke complication prevention, as of now the conventional management what we were using, the aspirin or either oral anticoagulants, like the warfarin and other vitamin K antagonists. They are available since last almost more than 50 years worldwide. So, what is your clinical experience regarding this particular group of the drugs?
Well, it has stood the test of time. That's the first thing that I want to convey. And it's a cheap drug, both aspirin as well as warfarin. But then I really can't give you the statistics where what percentage of patients with atrial fibrillation, when they really deserve this molecule, what percentage are on these medications. But then overall, I think we are all scared about the bleeding tendency with warfarin. So until unless you have a proper laboratory measure to really have a very standardized blood test, and which is difficult in most of the centers, even in the best centers also sometimes it's a problem. So that's one of the major limitations, and so mostly what happens in the Indian context, I think the physicians tend to probably undercorrect the anticoagulant level so that you don't have the bad complication of a bleeding tendency. So from that perspective, I think maybe most of these patients are undertreated. But then I think overall, if it's just a proximal atrial fibrillation, I really don't think that you need so much of oral anticoagulants. You really have to decide clinically whether they merit an anticoagulant. But if they really merit an anticoagulant, then I think warfarin is not a bad choice. But then we all know the problems with warfarin.
Okay. So, sir, have you found any kind of the real kind of the challenges with this kind of use of the drug VKs in a patient, that you have given the drugs to the patient and there may be a long-term follow-up is not there, and when the patient will come, then iron level may be disrupted. So, have you found this kind of challenges?
This is a problem when you have a really very elderly patient. Well, there is no one to take care of the patient, and then they can really schedule their visits for a frequent lab test, and then those are the group of patients where you sometimes end up seeing them with a very high INR, and they keep on taking these medicines, and then of course there are a lot of other medicines they are on along with this medicine, so there may be a drug interaction. So that's a problem. I would say less than 5% of my population will have that. But most of them, I think, if you educate them properly, they do come back for a blood test, and then also, I think the rapport with the treating doctor is perhaps more important that way.
Sure. Definitely. So, regarding these challenges are there, but definitely proper awareness and counseling of a patients definitely will help and reduce all the kind of challenges also is very well. So, now if we talk about the newer generation of oral anticoagulants, which has recently just within 4 or 5 years, last 4 or 5 years, it has been launched in India as well. So, what is your currently take on this particular group of the drugs, where the rivaroxaban, dabigatran, and apixaban, now they are available in India, and they have proven that they are at least non-inferior to the VKS and safer side as compared to the warfarin as well. So, how do you opine on this particular?
Well, it's a welcome change. I'm saying no doubt, because when these molecules have perhaps the next generation agents which you use in this sitting. But then my experience has mostly been with dabigatran. So it's a good molecule, but then again we tend to be careful in patients, particularly elderly patients who have some renal impairment and all that. But then they have too many different dosage schedules available. So that's one of the advantages with dabigatran. And then maybe because that was the first molecule which came into India, so our experience definitely is much larger with that. But then it's a good molecule. We have not had major problems with that. Again, the advantage of not putting through somebody to all these frequent blood tests, but then the main concern is the cost.
Yes.
So that's a major issue, and we also have a policy in our hospital where apart from atrial fibrillation, the other area where we use is for a venous thromboembolism prophylaxis there. So there also we tend to use this in a very sizable amount of the patients. It's a good molecule. We have never had major problems. Once or twice I had patients with apixaban coming with bleeding tendencies, but once they have a bleeding problem, it's perhaps a little more difficult to control than because not only the antidotes have just come into the market, the newer antibodies and all that. So that's a little more trickier situation, because warfarin, the way to counteract, and it's a very predictable way to do it. So that's the only concern which I have. Of course, rivaroxaban again just new to the Indian market, and I'm sure it should also work the same way with. Personally, I don't think there is anything to choose apart from the fact that dabigatran is a problem. If you read into literature, you're scared when you have a patient with a chance of them getting a myocardial infarction. But then the same thing was said about rosiglitazone. It went away from the market. Now it's come back again. So I think it's just probably early days. To talk about all this.
Okay. So you have very well said that definitely MI is the part of some major concern with the dabigatran, but still it's non-significant. So we cannot say anything about this particular side effect on this particular drug. So, sir, just you said that the rivaroxaban, apixaban, dabigatran, all three are more or less equal. They don't have any head-to-head comparison as of now. But still, if you have a choice to choose a one agent in different subgroup of the patients, like renal failure, patient had prior history of MI, prior history of GI bleed, then in this different segmentation, how will you place this all the molecules?
Well, in an ACS situation, I would definitely avoid dabigatran because with the kind of negative data that you have about it, that's one thing for sure. But apart from that, I think dabigatran has an advantage where you can even use it in a dosage of 75 milligram twice daily, renal impaired patients. So there's an advantage like that. But otherwise, I think in the context of I think in a routine practice, particularly for atrial fibrillation, it really doesn't make much of a difference.
Okay, that's sure. And sir, just last question is regarding that the stroke prevention in AF, it remains one of the lifelong therapy. So even the guidelines also suggest that the once patient is diagnosed with AF, then at least oral anticoagulant should be for a lifetime to prevent a stroke. So, and we have the data regarding the vitamin K antagonist that it is one of the poor compliable drugs that at the end of the 1 year and second year globally only the 25 to 30% of the patients are remain on a treatment, and the rest of the patients may either interrupted or discontinued the treatment. So in compare of that compliance point of view, this rivaroxaban and dabigatran and apixaban, how will you prefer that? Is it?
Let me put a counter question to you. May I ask? Well, we have the problem even with a post ACS patient. Just a simple aspirin and clopidogrel. People don't keep taking this. It's supposed to be aspirin supposed to be lifelong, and we find a lot of people coming back without any medications at all. Stop medication. From that perspective, I think it's just the same. I mean, nobody wants a drug to be taken for a longer time. But then warfarin, apart from the kind of, if patients are stable, let's say somebody is stable on a 5 milligram of warfarin and they do well without much bleeding tendency, then there is no major scare for them, and they would rather continue because it's a cheap molecule as such. But then the issue is when you have a negative effect because of that, so due to some bleeding tendency, then they are worried about it. Otherwise, all patients, they take it because they know for sure that if they have to really have a good quality of life, they need to have this molecule. So in that context, I think warfarin or any of the molecule just remains the same. The only difference I would feel is in terms of your INR monitoring. So the worry that this might just jump on to a higher level on a day, another day it would come down, plus the food interaction. That's an area of major concern. Many people are really scared about. Finally, whatever said and done, the food intake is also a very integral part of everyone's life. So that's one challenging area, and that's perhaps one area where the NUAC could probably replacement. But I think the bottom line is the cost should come down. So it's prohibitively expensive these days. I think it has to come down. Then I'm sure there's definitely a future for the newer oral anticoagulant agents.
So definitely your message is, sir, well we have taken. Now just in last, we need some 5 important takeaway for that, so that we can discuss these points to the physician as well as the patient's part, that for atrial fibrillation and the stroke prevention atrial fibrillation, what advice you want to give to the physician as well as the patients?
Yeah, first thing is you need to assess whether the patient really needs an oral anticoagulant. You have different criteria, the CHADS score and so on and so forth. And if you're convinced that the score is there, and then you need to put a patient on a oral anticoagulant, that's the way to go about. We all know for sure. And then you have the different choices. But then that's the advantage of this agent is that you have an advantage where you don't have to monitor the blood test very frequently. And renal impaired patients, in fact, I was reading the literature these days. Warfarin is also known to impair the renal function over a period of time. So perhaps that point of view, I think all of the newer agents are effective, and dabigatran also in a renally impaired patient could be used at a lower dosage. And newer molecules like rivaroxaban or apixaban, again, definitely has a place. There's no drug interaction, no food interaction. So that's, I think, one of the key things that this could be used. But then I think it's also important that this is a lifelong remedy, and one has to really look into the financial status of the patient as well. And one major area where I would feel this is useful is because when you start using an oral anticoagulant, particularly when there is a real indication for an oral, you always overlap it with heparin or low molecular weight heparin, which is not required for this molecule. It starts acting straight away. So that's one major advantage for the physicians, where they just start it on as an outpatient basis. They can easily monitor the patient. But then a word of caution, because when these patients come to you with a bleeding tendency, you really have to tackle this, because some of these are not really dialysable. But then sometimes you have to give a fresh frozen plasma, or then really take care of this problem. And then I think we still have to wait for the newer antidotes to come into the market for a for you to feel more comfortable about
like
this.
Idarucizumab is
Yes, just a monoclonal antibodies have to really come into the market and should be easily available. So it has definitely got a place. I think perhaps the future is this, but then I think industry also should see that the cost comes down and then it's patient friendly.
Surely. So definitely the sir has said very well that atrial fibrillation is a major concern of the society, and its diagnosis and awareness is also one of the major part that we have to focus on that. And if regarding we talk about the management, VKs are still it's a gold standard because the good efficacy and the cheaper rate they are available, and the NOACs has a bright future as compared to the VKs, but still apart from INR monitoring, if there is companies are focusing on a cost, then definitely it could be a next feature of this particular atrial fibrillation treatment. So sir, thanks a lot on behalf of us. That definitely we are thankful for your providing your time and your valuable opinions.
My pleasure.
Thanks a lot.
My pleasure.
Sure.
Thank you.